Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure of moderating today's tumor board. We have a very esteemed panel of individuals today with us, and so I'm going to ask them to each introduce themselves.
Hi, I'm Norman Womark. I've been around for a good many years, as perhaps some of you know. I'm chairman of the NSABP Foundation and one of the chairs for NRG Oncology and the contact PI for that group. And I'm professor of surgery at the University of Pittsburgh.
Hi, I'm Tom Buchholz. I'm a breast cancer radiation oncologist. I'm the medical director of Scripps MD Anderson Cancer Center and professor emeritus at MD Anderson Cancer Center in Houston.
Hi there, I'm Sarah Hurvitz. I'm at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. I'm professor of medicine and director of the breast oncology program there.
Hi, I'm not going to tell anybody how long I've been around, but I am the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am primarily a breast imager, but I also do PET imaging as well. So if I come on a PET scan, it does come with a little bit of experience in the background. I am a member at Memorial, which is the equivalent of a professor, and a professor at Cornell Weill as well.
Thank you so much to all of you for joining us today. I look forward to learning from each of you. This is a 49-year-old African-American female patient with a history of right-sided ductal carcinoma in situ. In 1996, she was status post bilateral mastectomies. So we're going to talk about how we would manage this patient in terms of her local regional recurrence, and given her reluctance to undergo initial therapy initially, would this change or impact our recommendations? And the patient does also have silicone implants in place. And so would that change the dose or fractionation scheme of radiation therapy? So as I mentioned, this is a 49-year-old patient with a history of DCIS in 2006 who presented actually with pain in her right breast. Her history includes DCIS, which was ER positive, PR positive, and HER2 negative diagnosed in the right breast in 2006. At that time, she was 35 years of age. She underwent a bilateral total mastectomy with right sentinel lymph node biopsy, found to have 0 of 3 lymph nodes involved by malignancy. And this was followed by immediate reconstruction of both breasts with silicone gel implants. She did not receive any subsequent anti-endocrine therapy or radiation therapy, and she received treatment in a survivorship clinic with annual surveillance ultrasounds, which were up to date and negative. She has an excellent performance status of 0. She has no other significant medical history other than the DCIS. Her last menstrual cycle was in 2019. She's not on oral contraceptives or hormone replacement, no alcohol or drug use. And of note, her mother was diagnosed with breast cancer at the age of 35. Dr. Jochelson, do you mind commenting on the ultrasound?
Sure. So just of interest, the American College of Radiology screening breast group has just reviewed the utility of routine screening imaging in women who have had bilateral mastectomies. And of interest, there are no data to suggest that any routine screening in that setting is of clinical value. I mean, certainly we did find the cancer in this lady, but the data that have been demonstrated really don't show that you should be routinely screening these patients. Nevertheless, she did have a bilateral breast ultrasound, and they did in fact find a hypoechoic lesion that was sub-centimeter in her right breast. And I know it said stage 1A. I never give a stage after recurrent disease. I'm not sure about that. And then the description, and I don't have the images of multiple suspicious right axillary nodes, the largest of which was 4.1 cm. But again, as I had said earlier, it's really about anatomy. It's not about size. And so she underwent an ultrasound-guided core biopsy that demonstrated that she did have breast cancer. And as far as I know, she had no other imaging workup. And the one thing that I think should be standard in a patient who does have recurrent, locally recurrent or new disease in the setting is that systemic staging is probably worthwhile. The data definitely demonstrate that there is a significant pickup in that setting.
Thank you. Dr. Hurvitz, do you want to comment about the fact that this particular patient has not yet undergone genetic testing? Would that be a consideration for you when you were meeting this patient in consultation?
Yeah, a 35-year-old woman who is diagnosed with DCIS should really undergo genetic counseling and testing. That was fulfilled.
Because I think she's 49, but had her DCIS when she was 35.
Correct. And so I think even at 35, when she had DCIS, there would be data to support the use of screening, genetic testing at that time. And she's under the age of 50 now with an invasive breast cancer. So certainly genetic testing should be done.
Can you comment on what type of genetic testing, or would you approach her with a mother with a history of breast cancer as well? Would you approach her with targeted, just BRCA1 and 2 testing, or would you expand that to a more comprehensive genetic panel? And do you have a preferred panel that you use?
We do the panel that is most affordable or covered by the insurance, but we try and throw a wide net in these situations. Certainly, if there are other cancers that would indicate that we ensure we are testing for certain genes, then we will make sure that those are included. But there's a variety of panels now available, and the price has come down considerably given the market competition now with genetic testing. So our genetic counselors really work with the patients, determine what they're highest risk for, but usually will send a panel covering most of the genes that are implicated in the risk of breast cancer.
Perfect, thank you. So this patient, after undergoing a biopsy, was found to have a grade 3 ER positive, PR negative, and HER2 negative invasive cancer. And this was actually sent for a genomic assay. The 21 gene recurrence assay, or Oncotype DX, was found to have a relatively high recurrence score of 39. Dr. Hurvitz, can you walk us through what that means for you and how you interpret the results of this genomic assay?
So her genomic recurrence score is quite high, and chemotherapy is certainly indicated, even though clinically she hasn't had surgery yet. She's had a biopsy of a suspicious node that was negative, but clinically she appears to be a stage 1 based on the imaging and based on the biopsy of the one node. And so chemotherapy would still be recommended. She's a young woman, premenopausal. There is data to support the use of chemotherapy, strongly supports the use of chemotherapy in any patient with a high-risk Oncotype DX score like this particular situation. The question becomes which chemotherapy should be used. There are two options that can be discussed: an anthracycline taxane-based regimen or a taxane-based regimen alone, for example, docetaxel cyclophosphamide. The ABC clinical trial, which was a compilation of 3 studies combined together, compared TC versus TAC and indicated a small but statistically significant improvement in disease-free survival of 2.5% overall associated with benefit with an anthracycline. Subgroup analysis seemed to indicate that stage 1 ER positive tumors don't appear to benefit from the addition of an anthracycline, but I think it is fair to discuss the use of an anthracycline in this situation, given the patient's young age. I would prefer to treat this particular tumor, even though it's ER positive, given its high risk score. I assume it's high grade. I can't recall if it is, but I assume it is. Yeah, I would prefer to treat this in the neoadjuvant setting, although that's a bit controversial because it isn't a large tumor, and she probably could undergo surgery at this point right now. But I like understanding how the patient's tumor is responding to the chemo that I have selected in this particular case, where I do think it's behaving not like a luminal type breast cancer, but more like a basal-like type breast cancer. That's why I'm extremely interested in knowing what her genetic test results are.
I think it's important in this case too. Again, this is a local recurrence after mastectomy, and obviously with the prolonged period of time, that's an unusual feature. And with her strong family history and her young age, one has to consider whether this is a new primary despite having a mastectomy, and it would be helpful to carefully evaluate the pathology and see if you see breast tissue in addition to the biopsy, or if you see ductal carcinoma in situ associated with this, implying that there's residual breast tissue despite having a mastectomy. We know that mastectomy, depending on how it's done, but by and large, you could still have residual breast tissue, which could be a nidus of a new breast cancer, which actually for her would be a much better prognosis. Her pathology sounded like it was involving skeletal muscle and that fibrous tissue that sounds very analogous to it really being a true chest wall recurrence rather than at least histologically a new primary. Those people have a significantly worse prognosis in a stage 1 breast cancer. And I agree that systemic rule out metastases systemically with a systemic workup is appropriate. And I would think we'd need a combined modality, multidisciplinary chemotherapy, resection of the recurrence, axillary lymph node dissection in this case. If with multiple positive axillary lymph or suspicious axillary lymph nodes, I would work with the radiologist to determine, is there a potential sampling error in the initial negative one? Do we need to clarify that? And then comprehensive radiation would be a component of the treatment at the end, in addition to obviously hormonal therapy adjuvantly.
Thank you so much. Dr. Woolmark, do you want to comment about in these patients where there's this question of recurrent disease versus new primary, and then also about her existing reconstruction? How does that affect your surgical approach when you have patients that present to you with this situation?
Yeah, I'd be curious to know exactly where this lesion is. With a 15-year hiatus following a diagnosis of DCIS and bilateral mastectomies, I would think this is a de novo lesion. And just as Dr. Buchholz noted, I think with skin-sparing mastectomies today, the likelihood of leaving behind residual breast tissue I think is significant and is greater and greater rather than what we were accustomed to when mastectomies were being done anatomically. I'm curious about the so-called muscle invasion. This is in a post-operative setting, and were there satellites of breast tissue left behind, and that the fascia was vulnerated by the operative procedure for DCIS. So from my perspective, this is a high-risk ER-positive de novo tumor. The disparity between the imaging findings in the axilla and the negative node is disconcerting, and I would revisit that certainly, particularly if the nodes appear suspicious, and make certain that they were biopsied, and we'd know a priori. My enthusiasm for using neoadjuvant therapy in this setting, and we certainly were very enthusiastic going back to B18 and B27, is limited, because at best I think we're going to get a PCR here in the range of 15%. And I'm not sure that in a situation where one can do a definitive operative procedure without undertaking any heroic measures, that I would be sanguine about neoadjuvant therapy. Having said that, I think I would proceed with an operative resection after I was certain what the axillary status was, resecting the tumor and doing the appropriate procedure for the axilla, and doing that without neoadjuvant therapy.
Okay, thank you for that. Can you comment about the placement of her previous implants? Does that influence your surgical approach at all? And has the placement of the implants evolved over time such that that's something we take into account when you're planning your surgical approach?
I plan to resect the tumor rather than the implant. So from my perspective, that's the preeminent and predominant focus for me.
Okay. Would you feel comfortable leaving the implants behind, or do you feel that the implant would need to be removed as well? And
I have left implants behind.
Okay.
I'm not suggesting that that this is something for the people who are watching this to emulate, but I have certainly done it.
Most of the implants historically have been underneath the pectoralis, so that the rest tissue is superficial to the implant. There is kind of, as your question annotated, there is now a kind of a newer approach to having it be on top of the pectoralis, which of course then conveys a different area of risk that's deep to the implant. But in this particular setting, I think it's quite reasonable, as Dr. Womark was saying, to resect the area of disease risk and use radiation to treat the remainder of the chest wall. The other consideration with respect to removal of the implant has to do with the design of the radiation fields, and that's going to be highly dependent on individual anatomy. I would want to treat the chest wall and draining lymphatics, inclusive of the internal mammary lymph nodes. Whatever axillary lymph nodes are not resected surgically, including the level 3 axilla and the supraclavicular fossa for a chest wall recurrent case. And accordingly, sometimes the design of the radiation field to adequately treat the chest wall and the internal mammary lymph nodes can be interfered by a really large implant. The second consequence is that radiation is going to have an adverse effect on the cosmetic appearance of her silicone implants moving forward. And another potential option would be if she had significant amount of tissue elsewhere, that she could have an autologous delayed post-radiation delayed reconstruction. That would be kind of another consideration that might give her long-term a little bit better cosmetic result, because the radiation will have an adverse effect, I think, moving forward over time on the cosmetic appearance and fibrosis, et cetera, around the implant.
At the risk of bringing up a controversial topic, and I am not a person who believes all patients need to have MRIs every time they get diagnosed, but in a lady like this, would you, Dr. Womark, or you, Dr. Buchholz, consider doing an MRI just because it's so hard to really get a good picture of the extent of disease with an implant in place in this setting?
Absolutely, yes.
Yeah,
I think so too. I want to go in there without an MRI.
Yeah, I think so too. I think it would be helpful in that setting.
And the disparity between the description of the nodes, and certainly, as you point out, I mean, the size is not an issue, at least in this particular situation. But we see on this slide, we haven't quite gotten to this point, but 0.4 positive nodes in this setting. I would want to revisit or make certain that that we were targeting the appropriate lymph nodes in the axilla.
Yes. So as you mentioned, this patient went on to undergo lumpectomy. Pathology demonstrated a poorly differentiated invasive ductal carcinoma, with DCIS solid type. There was a 1 centimeter in greatest dimension of the invasive disease invading the skeletal muscle. This was classified as a positive margin, and 0 of 4 lymph nodes were found to be involved. So her stage at this point is recurrent T1B in 0. Systemic staging completed did not demonstrate any evidence of systemic disease. So can I have my local treaters, Dr. Buchholz and Dr. Wohlmark, comment about this invasion into the skeletal muscle and the positive margin after surgery? How would you approach that moving forward?
You know, for 1 centimeter lesion, the invasive ductal component to be invading the skeletal muscle, as we discussed previously, is unusual. And I think we have to wonder whether this really is a tumor that breached the fascia because of its virulent nature, or whether this was an artifact that was created by the initial operation, and I would certainly want to factor that in. So you know, I think I would re-resect that area. We're already committed to utilizing radiotherapy in this instance, and I don't think I would do more relative to the local resection component of the operative procedure.
Thank you. I
do not have equipoise relative to the axilla with this.
I think when I talk to patients like this, I always love to start with good news, right? And there are a lot of pieces of good news here for someone who's having a local regional recurrence after having mastectomy. And the best news, I think, again, is a grade 3 DCIS. That, as we talked about earlier, implies that this is most likely, almost certainly, a new primary recurrence, rather than persistent disease left behind. The time course, the fact that she has probably a strong genetic component to development of breast cancer, the finding that we're finding breast tissue, which by definition means DCIS, suggests that this might behave like an early stage breast cancer.
Right. So Tom, I was confused there as well. I think she has an invasive grade 3 ductal carcinoma with concomitant DCIS, which I think, other than supporting the fact that this is residual breast tissue, as far as her treatment is essentially irrelevant.
I agree. I think I would categorize her as having a chest wall recurrence, and within that category, that has a relatively poor prognosis in terms of prognosis, but within that category, her prolonged length of interval before having a recurrence is in her favor. The lymph node negativity is in her favor, and the fact that you're finding DCIS again suggests that this might behave like a de novo cancer rather than a chest wall recurrence. I think is the point I was trying to make. When you have post-mastectomy chest wall recurrence, it's very common to see invasion of skeletal muscle, unlike, as Dr. Wohlmark was saying, a brand new breast primary within breast tissue. Should we treat her regional lymph nodes? You could say she never had lymph node involvement. Now she has 4 lymph nodes. Well, I think in the setting where you've had a mastectomy and now you have lymphovascular space invasion, the reliability of a sentinel lymph node procedure is less certain than in the setting of intact breast tissue. I'm glad that the lymph nodes are negative. I would still be inclined. I don't think that the morbidity, we're going to use radiation, the morbidity of adding regional lymph node radiation for her is really quite low. And I certainly would favor of being aggressive in our one shot for curability here with local regional management, and would be targeting the chest wall, level 1 through 3 axilla, supraclavicular fossa, and upper internal mammary lymph nodes.
Thank you. So this patient actually, due to the positive margin, underwent a re-resection or a repeat lumpectomy that demonstrated an additional portion of invasive ductal carcinoma of 0.1 centimeters, which was seen to be invading the skeletal muscle. The margins after the re-resection were negative and measured at 0.2 centimeters from the closest margin. There was noted to be tumor emboli present in transit within the intramuscular lymphovascular spaces. Dr. Buchholz, can you comment about how that would or would not affect your radiation planning for this patient?
Well, I think, again, that's suggesting a more aggressive type of biology. It's a consideration. Because of the fact that I was being more comprehensive to start, even without that, this just makes you feel better, like that's the right answer, but I don't think it necessarily will affect. I agree with having the re-excision, and I'm glad that was done, and I'm glad that we're in a state now where we're using radiation without any evidence of gross disease present at the time of treatment. So this, she should do well in terms of her prevention of subsequent local regional recurrences. I'm glad she got systemic treatments. I know probably Sarah would be advocating that she get treated with hormonal therapy in the adjuvant setting. And so I think I'm optimistic for her outcome.
Thank you.
Are we comfortable with intravascular lymphatic emboli in skeletal muscle? I mean, I think the lymphatic emboli were probably in residual breast tissue or in the tumor.
That could be vascular emboli, again, suggesting a higher risk of distant recurrence.
Dr. Hurvitz, is that pathologic detail of her pathology, does that influence which regimen you might choose for her adjuvant therapy? Does that have any bearing for you at all in terms of whether you might be persuaded to choose an anthracycline containing regimen or not, given that you have negative lymph nodes, however you have these tumor emboli which are seen in transit within the lymphovascular space?
It tells us nothing about which systemic therapy we should choose. We know she has a very high risk of recurrence given her recurrence score, the high grade nature of the tumor, the lack of progesterone receptor expression. This is a tumor that needs to be taken seriously. And so the patient should have a discussion regarding anthracycline-based and non-anthracycline-based regimens. As I've said repeatedly, she should have genetic testing as well. And I think that, the use of docetaxel cyclophosphamide is a reasonable regimen based on not only the ABC trial, but Plan B, MIND-ACT, and other studies that have looked at anthracycline versus non-anthracycline-based taxane regimens. For a stage 1, technically ER-positive tumor, it's reasonable. However, this particular situation does raise eyebrows because of its high-grade nature, and so I think it is also reasonable to discuss an anthracycline-based regimen with her, given these biological factors. The emboli themselves don't tell us one way or another which way to go, but this is a tumor to be taken seriously. So I agree with what Dr. Buchholz says. After the chemotherapy, I would proceed with anti-estrogen therapy, which could be tamoxifen followed by an aromatase inhibitor when she's in menopause, or to be more aggressive, ovarian suppression with an aromatase inhibitor from the start.
Perfect. Thank you so much.
Relative to anthracyclines, I mean, the ABC trials, which B49 and B46 were the bulk of that. The effect of anthracyclines in ER-positive patients was virtually limited to the subset with positive nodes.
Right.
Having said that, the fact that there was lymphovascular invasion, I think would certainly support the use of an anthracycline-based regimen. Although I would certainly not draw a line in the sand.
So Sarah, now when are you considering CDK4 inhibitors in addition to endocrine treatment in higher risk hormonal positive treatments without clear metastatic disease?
I am not using it routinely. Unless we expect that the patient truly has metastatic disease. For example, a patient with 24 positive lymph nodes at the time of axillary dissection. We may get to the data in a different case later this morning, but the data is inconsistent. We have 2 negative studies with palbociclib and 1 positive study with abemaciclib with very short follow-up. The Penelope B trial with palbociclib had long follow-up. And if you look at the Kaplan-Meier curves at the early time point, sort of overlay them with the Penelope B 2-year invasive disease-free survival, they look very similar, but with longer follow-up. After the CDK4/6 inhibitor had been stopped in the majority of patients, the curves came together. So these drugs, we do not know if they are going to improve cure rates. We do know they have a risk of pneumonitis, venous thromboembolic events, neutropenia, and other issues that are, potentially serious in the curative setting. So I'll try and put the patient on the Natalie clinical trial if she's high enough risk, which is ongoing, looking at ribociclib in the adjuvant setting. If abemaciclib is approved in this setting based on monarchE, I'll discuss the data with my patients. And if a patient would have qualified for monarchE, I might be tempted to put them on abemaciclib, but I'll be watching the long-term follow-up data very carefully.
Thank you.
Thank you so much for that discussion.